everyone. This is Ellen Avery. I am the medical advisor for the ketogenic diet with Nutricia. Thank you all for joining us today for our webinar, Achieving Optimal Vitamin and Mineral Supplementation on the Medical Ketogenic Diet for Epilepsy. Before we begin our webinar, I'd like to give you a little bit of background on Keto University. Keto University began as a 3-day live conference, but given the situation, we have had to transition our live series of webinars to a webinar series. Our webinars are given by a series of experts in the medical ketogenic diet. We have 10 webinars in total, and so far we've gone through 3 of them. Today we have Stacy Bissoni with us to present on achieving optimal vitamin and mineral supplementation for patients on the medical ketogenic diet. Let me give you a little bit of background on Stacy. She is a registered dietitian at Johns Hopkins All Children's Hospital in St. Petersburg, Florida, where she is also an instructor of pediatric neurology at the Johns Hopkins University School of Medicine. Her practice is devoted exclusively to all forms of the ketogenic diet in both inpatient and clinical settings. Stacy received her Bachelor of Science degree in Dietetics and Nutrition from Florida International University in Miami, Florida, and she has concentrated her 24 years of experience as a dietitian in pediatrics. She routinely provides presentations to physicians and residents and has spoken nationally on the classic ketogenic diet as well as the modified Atkins diet. She has a passion for the diet and educating others to increase awareness of dietary therapies as a viable treatment option for epilepsy and other neurological disorders. Now, before I pass it off to Stacy, I do want to go over a few housekeeping rules. All of your phone lines are muted, so we ask that if you have any questions throughout the presentation, if you could please put them in the Q&A box and we will answer them at the end of the presentation. Also, if you weren't able to download a copy of the handouts at the beginning, there is a link in the Q&A box as well where you can get a copy of the PDF of the handout. We will also be recording today's session, and that recording will be available on our Nutrition Learning Center website within a couple of weeks of the webinar session. With that, I'd like to pass it off to Stacy for today's webinar.
Hello, everyone. I'm so happy to be joining you today to review supplementation for patients on the ketogenic diet. I hope you walk away from this webinar with a few pearls to assist your patients with meeting their vitamin and mineral needs. My disclosure as a consultant for Nutricia. The objectives for today is identification of vitamin and mineral concerns for the diet, review of some various supplements that can be used for the diet, and lastly, lab work that can be used to help identify deficiencies and also monitor for any side effects from the diet. As expected, a diet with limited variety of foods will be deficient in vitamins and minerals. For the ketogenic diet in particular, the carbohydrate and protein sources, which may contain a lot of nutrients, are limited, and that will also limit certain vitamins and minerals. For example, cereal is very high in carbs and sugar and eliminated from the diet, but it may have been a rich source of vitamins and minerals for many patients. Kossoff described this in 2008 in a publication. Beth Supakania published a paper analyzing the diet and how with each increase in ratio, the intake of required levels of vitamins and minerals would decrease. This paper is so significant as it is a reinforcement of the importance of supplements and how critical it is that patients take them as recommended, as if they are medications. These are the most common vitamin and minerals that will not be met on the ketogenic diet. This list can become larger and even more limited when you take into account the pediatric patient that may only prefer 3 to 4 menus total for their nutrition prescription, essentially eating the exact same meals every day. So we will review and go through these in a little more detail. First, we will review vitamin D. I would say with obtaining baseline labs, roughly half of the patients we see already have some kind of insufficiency of vitamin D, and they often require increased doses even at initiation of the diet. The mechanism of action promotes bone formation and regulates calcium and phos, and deficiency can be actually sunlight and diet, and surprisingly, even in Florida, where I live, many patients with their seizure issues have sensitivity to heat and light and may not get a lot of sunlight, so we do see a lot of deficiency here. The most common physical side effects you'll see of a deficiency of D is poor bone health, aching hands, legs, and joints, lethargy, sometimes cramps, and often dental issues. This is an X-ray of rickets or osteomalacia. It is actually very rare, less than 1,000 cases per year in the U.S., but as you can see from the X-rays, you can see the bone demineralization as well as the bowed legs. The test we use is the vitamin D25OH, or the 25-hydroxy vitamin D test. To correct insufficiencies and deficiencies, we prescribe various doses, either daily, or the doctor may prescribe a 50,000 IU weekly for 6 to 8 weeks, and then we check levels. Commonly, we use vitamin D3 drops because most of them come in oil and they're very easy to take. But we also use tablets that also contain calcium, a vitamin D calcium combination, because many of these patients require both calcium and vitamin D. The tablet is quite large, so the patient can use a vitamin D drop with calcium powder instead of trying to swallow it. I did list the Nature's Bounty here. That's a combination. Sometimes there's a 500 with 600 IUs, and also there's several other brands where you can find similar tablets. Next up is calcium. Calcium is very important for bone health. Deficiencies are usually from diet, but they can also be from various drugs, such as phenytoin and phenobarbital, and also vitamin D deficiency can contribute. Luckily, there are many dark greens that can be incorporated into the ketogenic diet that are rich sources of calcium. And a physical exam may reveal lines on fingernails. Patient may have fractures. They may have cramps. The most common lab we use to look at calcium is the total calcium, which would be in a panel. And we also sometimes, if we have a concern for deficiency, may check kidney function test, mag-phos, and vitamin D. To correct the deficiency, we use supplements. There are tablets, but also, as mentioned before, there's also pure powders available that are easy to put in food or in a feeding tube. As you can see here, the DRI ranges change as the years change. And we try to supplement just at the DRI level, not over or under. I believe calcium is really best supplemented in the right amount as to prevent kidney stones or other problems. Zinc is another mineral with limited intake on the diet. The action of zinc is that it helps with tissue growth and healing. Many signs you will see in the nutrition-focused physical exam will be skin-related, including poor wound healing and rashes such as eczema. Additionally, often there can be changes in taste and smell. Deficiency is usually due to lack of consumption of zinc. Luckily, sources such as meat, seafood, nuts, and seeds fit well into the ketogenic diet. Also to note, zinc can inhibit copper. There was actually a paper in 2013 of a patient that had copper deficiency due to over-supplementation of zinc, and this was a little guy on the ketogenic diet that had Acidosis syndrome. You can use plasma zinc to test the levels, but if the patient has low albumin, you may need to measure it in neutrophils or lymphocytes instead of serum. Also, a low alk phos may be a sign as well. To correct a zinc deficiency, you can dose 1 to 2 milligrams per kilogram per day of elemental zinc. I recommend starting at a lower dose and working up slowly to avoid stomach problems, stomach upset and diarrhea. This is an example of a supplement, a tablet supplement that's 30 milligrams. You could use something equivalent. This is a picture of two different patients with acrodermatitis that was caused by a zinc deficiency. I've actually had one patient over the years that did have acrodermatitis on his back, and this patient was on the diet for quite a while, and he also had Crohn's disease, so he had some malabsorption issues. Next, we'll review selenium. As noted from several papers in the literature, this is a very important mineral to monitor. Selenium's main job is to convert thyroid hormone. The main cause of deficiency is a diet poor in selenium. However, intestinal function is also something to consider. The main sources for the ketogenic diet would be meats and dairy, and also Brazil nuts. And one of the side effects of deficiency is cardiomyopathy, which is why it's so important to get lab work and maintain a good selenium level. For a nutrition-focused physical exam, hair color changes are seen very often, and also if the patient is over-supplemented with zinc, there may be some discolorations in fingernails. Serum selenium is the most common lab we use to check levels. Supplementation will help correct the deficiency. There's several examples of tablets listed here, 100 and 200 microgram tablets. I also use a Brazil nut, usually about a half to one a day, depending on the patient's age, and this may meet the selenium needs for these patients that may also be taking a chewable vitamin that is not rich in minerals. So often we'll kind of prescribe it like a vitamin. Meeting phosphorus needs can also be quite challenging. The action of phosphorus is aiding in bone health and muscle nerve function. The diet a low phosphorus diet would usually be the cause of a deficiency. On the ketogenic diet, foods that contain phos would be dairy, seeds, and nuts. And physical signs of deficiency are commonly muscle weakness and poor bone health. To monitor phos, we check serum levels minimally every 6 months. We often suggest various foods that are higher in phosphorus to incorporate into menus to help prevent deficiency. Supplements are by prescription and do require some additional monitoring. We try to at least meet 75 or 80% of the recommended intake and suggest high phos foods, and then kind of monitor from there to try to avoid some of the prescriptions. Iron needs can also be hard to meet on the diet. Iron is important for good blood health. A deficiency can stem from poor intake, poor absorption, or blood loss. Physically, a patient with low iron may demonstrate cracks in their mouth, brittle nails, pale skin, and tongue. There is also symptomology listed for toxicity, including joint pain and skin color changes, and for more severe things like liver and heart issues. Lab work for iron includes a CBC as well as an iron profile that may include things such as ferritin, folic acid, and B12. To correct a deficiency, ferrous sulfate is used 3 to 5 milligrams per kilogram, and we usually use that in a prescription form. Additionally, potassium intake can be low on the diet as well. Potassium is critical for health. For a normal range of potassium is critical for good health. A low intake of potassium would be the cause of the deficiency. And good sources of potassium include fruits and vegetables, avocado, and some nuts. Cramps are a common physical sign of low potassium. Plasma potassium is checked in a basic metabolic panel. Common sources for supplementation include prescribed supplements such as KCl. Sometimes if the patient does not have access to prescriptions or the prescription is too high in carb, we will use light salt, or Now Foods, which is a brand that makes a calcium chloride powder. And we did have a patient before that once they were supplemented potassium had an increase in seizures because of the carbohydrate content. In the next section, we'll review some tips on general supplementation. So for patients that eat by mouth, we try to meet 100% of the DRIs with supplements and not take into account any foods. Most need both vitamin and mineral plus an additional calcium and vitamin D. We try to use tablets as much as possible, but there are also various options that I'll review in a moment. For tube feeding patients, we review daily intake from formula and add additional supplements as needed. Most often, vitamin D and calcium are needed, and occasionally some electrolytes. Some patients with high calorie requirements may actually meet all their needs in the formula. You can use tablets that are crushed, or you can use also powders through the tube. Additionally, some patients may require sodium and potassium supplementation. Also, iodized salt can be used to meet iodine needs. For the tube-fed patient, these can be incorporated in their recipe. For the orally fed patients, they can be sprinkled on food. For example, younger orally fed patients that are starting to incorporate solids, I often find they usually need vitamin A, C, and iodine, so we try to use high vitamin C, high vitamin A baby foods and sprinkle them with iodized salts. These are some various formulations of supplements that are low in carbohydrate. At the top, the three powders at the top, the Flexivits, Nano, and FruityVits, these are complete vitamins. They meet 100% of needs based on age, and they're kind of broken up into different age groups. And they're great for a tube feeding or an oral patient that will drink them. They do also include phosphorus. I also listed calcium powder here. There's pure calcium powder. It's a great addition to vitamin D drops. The intake is very small to meet needs. It's usually a 1/4 to half a teaspoon, so it can be hidden in food or drink. Other vitamins I listed here are just some suggestions of resources that I use. Things that are equivalent would be great that are available to you. One is Rendo's Picky Eater. This is a meltable made with monk fruit, and it doesn't have any carbohydrate in it. They also have some B and other vitamins available. And the second is the Super Mini capsules that is a children's multivitamin, and you may have to use 2 or 3 capsules, but it's very small, so they're very easy to swallow. To keep up with patients' changing vitamin and mineral needs with age, it is important to check in at follow-up appointments to see if adjustments are required. So I always try to do a little run-through of their age group to see if we need to adjust their supplementation when they are at a visit. Other supplementation may also be used on the diet, such as carnitine supplementation. This can be required since it is used to metabolize the diet. So if the patient is low, you may need to supplement based on their levels. I know some clinics use it prophylactically. We use it based on lab work. We monitor it by obtaining a free carnitine level from a patient that did not take their supplement that morning, and a start range is 25 to 50 milligrams per kilogram, and make sure to divide it into doses because it can cause stomach upset. The example here was Carnitor. I know there are other various brands or sometimes over-the-counter type things. Another thing to note, patients on Depakote may need it since carnitine competes with Depakote for the use of carnitine. Well, let me back up. Depakote competes with the diet for carnitine use. So Depakote is metabolized by using carnitine, and obviously carnitine is used for the diet. Other supplementation may include things for kidney stone prevention. This may be baking soda. We actually don't use baking soda here at our clinic, but often people do. We do use potassium citrate. We try to put all tube feeders on it and oral eaters if they will take it. We previously used the citric A crystals, but since being discontinued, we've started adding the solution in the white bottle, which has 100 milligrams of carb per ml, and we try to add it into the diet and adjust the ratio if needed, and that's seemed to work very well. There are also some others. Uracil K is on there. There's 3 different doses of that are fairly low in carbohydrate. I believe those don't go through a G-tube, and there's a couple other ones, but I haven't personally used them. Sometimes we need to supplement for acidosis, and we do the dose based on how low their carbohydrate level is. Often we use sodium bicarbonate tablets. They're easy to use. They're crushable and can go through the tube. The tablets can be used to correct the CO2, but other changes may need to be made to the calories, ratio, or hydration if the acidosis is not from an acute event, such as illness. Other supplementation, occasionally for malabsorption or fat metabolism improvement, pancreatic enzymes may be used. I have had a patient with cystic fibrosis that was actually on the ketogenic diet and was very successful on a lower ratio using BioCase for her tube feedings. Sometimes we supplement fiber and fish oils. A lot of the fiber sources do have carbohydrate, but an example of one that's low is Senecot, and there's some other tablets that should work as well if the patient can swallow. And obviously, adequate fluid intake is imperative for those patients. You can also consider things like flaxseed, chia seed, avocado, aloe vera juice. I've used avocado successfully with magnesium tablets. We've blended it for tube feeders. I've even mixed it in some of the formula. And for fish oils, you want to improve a patient's lipid profile, or parents would like to use them prophylactically. Nordic Naturals is a good brand that we use, specifically the Ultra Omega, and it's very low in carbohydrate. Some patients also want to use probiotics to support good gut health. Some examples are Culturelle, Florigen. You can also just incorporate pre- and probiotic foods in the meal plan. And recently I've had some patients using inulin, which I guess is kind of a cross between fiber and a prebiotic, but it's made from soaked chicory, and that can help as well. There are also something I call optional things that the parents want to add to the diet regimen. This could be CBD oil, hemp oil. I see a lot of patients that want to add elderberry for immune improvement, and there are some different drops of elderberry, but you have to kind of go through them. The elderberry drops for the infants don't have any carb in them, but when you upgrade to the toddlers, it has sugar. So just kind of read through the labels. We try to have families come clean if they're using these things so we can look for hidden carbohydrates. And if they're low enough, these products can be added to the diet without any trouble. Sometimes we may need to adjust the diet ratio to help, and sometimes, unfortunately, they have to be discontinued. Now we will briefly review labs and monitoring. These labs can help monitor for deficiencies, side effects, and provide a window of preventative interventions that may decrease side effects from the diet. This is the basic lab schedule for patients on the ketogenic diet. At baseline, they do receive a full lab set, which we will review in a moment, and at 1 month, maybe a subset of labs, but they do get labs every 3 months with more extensive monitoring, and this also depends on any abnormal findings and tolerance to the diet. These are the baseline labs. Vitamin D, acetylcarnitine is taken, and it's often may have been done previously if they had a metabolic workup pre-diet, so we look for that level. We do fasting lipids, urinalysis, CBC, CMP with FOSS-MAG, and look at the liver enzymes. Sometimes we also do a baseline selenium. I've actually seen patients with a selenium deficiency or a low selenium to start the diet, and we want to correct that before the diet intervention. Most routine labs are similar to the baseline labs, except selenium is added as a monitoring lab, as well as carnitine. We're looking at free and total to make sure they have adequate carnitine, and also sometimes doctors add in the anti-epileptics, and they want to check those as well. These labs are currently as needed. This is where some lab monitoring may come into play based on an abnormal previous lab. This could include some of the lab work used to check deficiencies, as we discussed in the beginning of the presentation, such as zinc levels or iron levels. Also, blood ketones or beta-hydroxybutyrate is listed, and that could be included if your clinic wanted to monitor blood ketones as well. If the patient is experiencing side effects, as noted in the left column, some additional monitoring may be required. Additional tests such as hepatic function tests and DEXA scans may be required to manage any issues. Some of these side effects may show up early in the diet or may present after the patient has been on the diet for a while. And also, if the patient comes in to start the diet and has a history of issues such as kidney stones or maybe bone fractures, you may want to use these as monitoring tools as well. So patients on the diet can have a slightly lower CO2 level, and treatment for a low CO2 is based on the presentation of the patient, such as irritability and vomiting, and or the provider's preference. A lot of physicians will have levels that they think are appropriate and where they want to treat and where they want to have their CO2. This is kind of an example of something we use in our clinic. Some options for management include citrates, baking soda, or sodium bicarbonate tablets. and we try to use these temporarily. If the patient has a chronic low CO2, we need to consider a ratio change, different calories, and better hydration. Lipid levels can be elevated, especially in the first 6 months of the diet. I often warn parents that they may increase the first 6 months, but come down the second 6 months. It is prudent to repeat the lipid profile if a result seems randomly high, but if the patient does develop a high lipid profile, we do try to intervene with different foods, carnitine, fish oils, and MCT. Ketones. So some clinics will test beta-hydroxy levels, and even some of our patients have point-of-care beta-hydroxy machines, such as that are similar to the blood glucose. We like to say that generally it's greater than 3 is good ketosis, and 4 to 7 is therapeutic, 4 to 7. You can also check urine ketones, acetoacetate. The goal is greater than 80 or moderate or second to the darkest color on the bottle. These can be very crude and affected by age, hydration, and how long the patient's been on the diet. So things like infants, they may have variable tests. 1 hour they're positive, 1 hour they're negative. And then also patients on the diets, more novel forms of the diet, such as modified Atkins, may spill less urine ketones over time. And the third ketone is acetone, which are the breath ketones, and those are measured by blowing into a machine, and we don't really use it here because most of our patients are little, but I could see that being effective for adults. But the main thing of all these ketones and measuring them is we're really just looking at the seizure control. It's the most important part of the assessment. As long as they are being consistent with the diet and their ketones are present or not present, if the seizure control is good and they're being consistent, we just try to move from there. So in summary, when seeing patients with deficiencies, we look for physical signs of deficiency, skin, hair, and nail problems. Be aware of medical things if they tell you they can't feel their legs, if they're confused, if they're very tired, and then also take into consideration any lab values that may be altered. In further summary, most of the ketogenic diet patients will require some sort of supplementation. There are many options of supplements to meet patients' requirements. A plan for supplementation can be individualized for each patient and evaluate labs and symptomology together to formulate the best plan. I hope you've enjoyed this presentation today and that some of the information will help you support patients in your practice. And now I'll turn it back over to Ellen we have time for questions.
All right. Thanks, Stacy, for that great presentation. We do have some time for questions, but I do want to let you all know for those people in the United States to get CE credit, there is you can either scan the QR code with your phone that will take you to the SurveyMonkey, or the link will be in the thank you email, as well as you can write it down and go to the website from there. And you can take the survey. We would appreciate it. We'd love to hear your feedback about today's presentation. That will also get you the code for the CE credit. You can enter that into nutritionlearningcenter.com in order to get your certificate to submit for CDR. But if you have questions, please put them in the Q&A box. We have had some that have already come in, so I can get started with those in the meantime. So Stacy, the first question, what do you think, have you ever had your patients come in on a personalized vitamin that has been prescribed for them, and what do you think of that if a pharmacy or a doctor has recommended some sort of a personalized vitamin?
So actually I have seen patients come in on personalized vitamins, and usually it's several of them to meet all the needs. So I just have the patients bring the bottle, and we will go through the ingredients and try to determine if they're high in carbohydrate. But mainly if they're starting the diet, if they want to continue that vitamin while on the diet, we basically just kind of start the diet and see if we need to make adjustments to get ketosis. or if we need to lower them or increase the fat, kind of adjust it, just see where they land, and then make adjustments from there if that's something the patient is choosing to continue.
Okay. Another question, for your citrates, can you go back to which citrate you're using now that citrate K is discontinued?
Yes, I will go back to that slide.
And how much carb was in it?
Okay, so I am still using potassium citrate. I'm using Citrate solution, and it's 2 MEQs per ml. I always put on there the white bottle. I know if you look in the keto calculator when you're calculating carbohydrates for meds and supplements, it has white bottle and brown bottle. So the white bottle is the lowest. The brown bottle actually has 200 milligrams of carb. The white only has 100 milligrams. And basically, I'll just take it and add it into the diet and see if we need to adjust the ratio. A lot of times, if it's a smaller patient and we're only doing maybe 1 or 1.5 MEQs per kilo per day, it'll fit with minimal change in the ratio, so it'll fit in okay. And others, I've had to add some MCT oil or emulsified MCT oil to the tube feeding or the formula to adjust it. So we are still using the Citrate. We're just using the solution right now. I know there are some other ones. The Uracet K I listed on there, there's 3 different doses. There's 3 different dosages. I haven't used those yet. We haven't had to because the solution's been doing okay, but there are some other things out there. I know on the listserv, some other people have been exploring some other citrates to help for kidney stone prevention.
Okay, thank you. And what brand of calcium powder are you using? Is there more than one brand, or is there a specific brand that you found that you like?
So I typically use the Now Foods pure calcium carbonate powder, and you'll find that in the keto calculator too. And it's really great because the doses are really small. You can almost put it in a little bite of food if the patient eats and not have to worry about them, trying to swallow a pill or anything. And then the vitamin D drop with that kind of makes a great combination. Also, I've had some patients where they really just needed a little extra calcium, and we can add it right to the formula during a feed, or we can treat it like a medication, and it'll dissolve in the water. So it's Now Foods is the one I see in particular. It's easy to get.
And then this question kind of goes along with that, with calcium and iron binding and iron not absorbing very well. Are you having to change the dosing of iron if patients need additional iron? And what iron dosing are you recommending for patients if they need additional iron supplementation? Or are you not finding that your patients need that?
Okay, let me go back. So for iron supplementation, if they have low iron, they're usually on ferrous sulfate. We use the prescription one, and the doctor will write that. I think it's 3 to 5 milligrams per kilogram. And just want to pull that up. Yes, ferrous sulfate. So I usually have patients take their calcium and vitamin D in the evening and take their multivitamin with iron in the morning, and that can help separate those the need for canceling out the calcium with the iron. So it's kind of like a vitamin schedule, and if they have more vitamins, we can divide it up into three different doses. But we kind of put them on the med list, and I'll have them take the multi and iron in the morning, or the multi with iron in the morning, and the calcium and D at night.
Okay, that helps separate it out. And for sodium, do you base your sodium supplementation on milliequivalents per kilogram? And if so, what is your goal milliequivalents per kilo?
So I base our sodium kind of on our hospital clinical practice, and we use the RDAs for sodium, potassium, and chloride. I will say I usually expect that the patient would at least meet those versus the DRIs, but a lot of times we will kind of look at the lab work, follow the lab work to see if we need to make adjustments. For example, if they're on trileptal or a drug that may cause sodium losses, or just being in high ketosis and having normal sodium losses from the diet, we do follow their lab work and adjust from there. And so I will use table salt either sprinkled on food or added to recipes for the diet, for the formula.
Okay. And then, are you concerned about going above the upper limit for niacin and folic acid? This question said that with supplementation, I often find I have niacin and folic acid above the upper limit. But if adjustments are made, then it's below the DRI for a lot of other things. So would you be concerned about that?
I honestly, no. I mean, I know it's a lot of times when you do add everything all together, some things are a bit high. I just try to base it on, I'm assuming this must be a formula patient. We just try to follow them closely, you know, to make sure they're not having any side effects from anything that we're giving them for the diet. And I haven't really had a problem with any of that. I do sometimes see things pretty high, but most of the time we just kind of go with the flow. If someone's eating, I may adjust that because it's a little easier to adjust their vitamins. The formula, it just depends. Sometimes the formula, if we're adding other things to it, some of that is kind of watered down. So I do get exact mLs of how much formula they would be taking daily, so that might help as well.
Okay, and how often are your patients having high carnitine levels? And if it's due to supplementation, would you wean it quickly, or what's your process for weaning? So I have only seen a few high carnitine levels, and a lot of times if you repeat the lab and they don't take their supplement that morning, because they get so used to taking it since it's on their med list, they'll come down. I've really only had a few that were so high that we had to cut back. Most of the time, if I start on a low dose, maybe 25 milligrams per kilogram, 30 milligrams per kilogram, you can retest their carnitine and it'll be in a nice level. I think it's when you go up too fast and don't see where their carnitine lands that you may have to cut back. I will say something about carnitine deficiency that I didn't mention. I've definitely seen patients that were on the diet long term, for example, a GLUT1 patient, and he started having seizures, something awful, and he had stopped taking his carnitine supplements, and his free carnitine was 9, and we added the carnitine back to his regimen, and his seizures went away. So I definitely think it can help metabolize the diet, and it can help affect the way the diet can work. So just a little side comment on that. Okay. Do you think it would help with any elevated liver function tests as well as elevated triglyceride levels?
So we have used it for elevated liver and seen improvement. And so I don't, as long as the doctor feels that it's appropriate, I really leave it up to the doctor since they prescribe it. And I have seen our physician use carnitine to help lower liver enzymes in several patients that did not have a carnitine deficiency.
Okay. Then there's a question about pre and probiotic strains. Do you have any recommendations for specific strains, or have you seen any evidence for which strains to recommend? Or I honestly don't recommend that many prebiotics. That's usually a patient-driven supplement.
I know Dr. Rowe, I know he's going to be speaking in a few weeks, and he has a lot of things about microbiome. And so usually what I tell patients, I don't have one that I considerably recommend. A lot of them are very expensive. A lot of my patients don't have the money to buy the really fancy ones that are very, have a lot of high dosage, but if they're on a prebiotic or probiotic, they can stay on it and start the diet, but I ask them not to start it after they've been on the diet unless they're having some kind of GI problem, just because I feel like we're learning so much about the microbiome and how the diet may work more on that level that I want to give the patient the best shot at the diet, and I don't want to interfere with that part of their treatment, but I really don't recommend a specific one. They usually come in on one already. That's either the doctor has prescribed it or they're getting it over the counter, which is the ones that I had listed.
Okay. And I think the Charlie Foundation also had something about pre and probiotics maybe too. I could be wrong about that, but I thought I remembered seeing something on the Charlie Foundation page about that.
Actually, they have a great page, a printout page that you can give parents that has a list of pre and probiotic foods that you can incorporate into the diet. And some of it's really helpful. It's even for patients that are on tube feedings, they could possibly add some of these things to the tube feeding, or if they're on a blenderized tube feeding, they can use the apple cider vinegar or some of these foods and just incorporate those foods naturally. So you're right. It's a handout on the table, the toolkit.
Okay. I was like, I feel like I remembered seeing something on there one time. But
yes,
yeah.
It's a good handout.
And just because we had it at Keto U last year. And then, do you ever measure fat-soluble vitamins? Lately, we've been seeing elevated vitamin E.
We haven't had to.
Okay.
Check them. We don't commonly check them. I think a lot of the basis that we go on is that most of these patients we're going to treat with a diet for 2 years. I mean, obviously, if they're GLUT1 patients or someone that's going to be on the diet longer, it's a different situation. So we kind of just monitor them in that bubble of the 2 years, and then if they are going to be on the diet longer, that would be someone that we may want to consider looking at fat-soluble vitamins, looking at a DEXA scan, just making sure that they're overall healthy in that aspect.
Okay. This question, for somebody who comes in with a deficiency, would you get the deficiency corrected before you started them on the diet, or would you kind of supplement and start them on the diet at the same time?
Most of the time we will start them and supplement at the same time unless it's something critical. And also you could evaluate the patient. Is this a patient that is having seizures all the time, every day? Is it more important to get their seizure control going versus, some of the supplements and things? But typically I wouldn't make a patient not start the diet for that. We would just go ahead and start supplementing. For example, I have a selenium deficiency that I actually put them on one supplement a few weeks ago, and they're supposed to start next week. But they're having daily seizures and they're getting worse. So I think it's kind of outweighing. And the same with malnutrition. I mean, obviously I know all the people on here, we have a lot of patients that are on that brink of bad nutrition just because of their situation, and we just kind of outweigh that too. Is it more important, could we get their seizures controlled and then help their nutrition kind of, outweigh all the risks and benefits?
Okay. Thank you, Stacy. And so this kind of, I guess, goes along with it for oral rehydration for patients with vomiting and diarrhea. How would you manage their ketogenic diet with oral rehydration and making sure they're getting adequate electrolytes? Does the risk outweigh the benefit of the ketogenic diet then, or?
So
how do you manage that?
Are they asking if a patient is sick, how I would hydrate them?
Yeah,
okay.
Get them oral rehydration.
Okay. So for sick days, we have a sick day guidelines. Okay. We do use
and I think
Pedialyte.
Robin will probably talk about that in 2 weeks, is my guess.
Okay.
But, yeah.
Okay. So just as a quick answer, we do use Pedialyte. We have the patients dilute it to half strength, and usually in 24 or really like 12 to 24-hour increments, we will either add back their formula, or if they're a patient that eats, we just try to really encourage them to eat some of their menus, or we may have them make like a keto shake if they can tolerate that better. But we do use the Pedialyte half strength, or you can use things like Powerade Zero or some of the electrolyte waters. I know Whole Foods has one too that's carbohydrate free. You just want to look for those as sources of electrolytes until the patient can eat again.
Okay. And then I see one more question. I often have labs showing slightly elevated serum calcium levels, even with supplementation that is not above 100% of the DRI. What are your thoughts? And would you be concerned about kidney stones?
If they're chronically high, we may refer them out just to make sure they're not having some kidney stones. We do get regular urinalysis, so we look for any sediment or crystals. And I do tell parents, too, even if we're supplementing the citrates, they still can get kidney stones. It's not a guarantee. Some kids are just going to get them no matter what we do. But if we have any labs that are chronic, we usually refer them to a specialist to make sure they can help with treatment for that, what the true sources of the elevated calcium. And as far as supplementing, we really try to just supplement right at the needs, nothing too high or too low. And then obviously we can look at bone health too.
Okay. And I think that is all of the questions that we had. So I want to thank everybody for attending today's webinar and encourage you all to provide us your feedback via the QR code or the link that you can see on the screen. If you can write that down and provide us your feedback, it will also, the link for the survey will also be in the thank you email that you'll receive probably within the next half an hour. And thank you, Stacy, for providing us with such wonderful information. I hope everybody enjoyed today's webinar, and you all have a wonderful day. Thanks so much.